welcome to our next live Facebook session. I'm here today with Dr. Manukyan and we are going to be talking about chronic daily headaches. I will be checking your questions, although we've already had a lot already, so we'll try to answer as many as we can. And that'll be at the end of the session. And first of all, what exactly is chronic daily headache? What does that mean exactly?
So chronic daily headache is just a term to reflect on the frequency of headaches people have. So it's having regularly for a few months or years headaches on more days than not throughout the month. So on its own, it's not a diagnosis, but it's just a symptom frequency. And the underlying reasons for chronic daily headache could be chronic migraine, chronic tension type headache, it could be chronic cluster headache, or new daily persistent headache, or medication overuse. And we could talk about some of those today.
Okay, brilliant. So what does chronic migraine mean then? Is that different?
Yes, so with episodic migraine is probably more frequent. So we know about 16-70% of people suffer with migraine, but chronic type of migraine is less frequent. It's only about 4% of population suffers with chronic migraine. So the criteria to diagnose is having headache days more than 15 days a month, and having them at least for 3 months, and with some migrainous features on at least 8 days a month. And so episodic migraine sometimes can change and turn into chronic migraine, depending on the frequency, and it's just a label to distinguish between maybe good run of migraines when they're infrequent and when they're quite bad and frequent, and we term them chronic migraines because treatment options are different.
And so why does migraine become chronic? Why does that happen?
So we don't know the actual reason. Sometimes it can happen very gradually, just when the underlying frequency of migraines is gradually increasing. Sometimes it can present for the first time with more and more like daily episodes of headache, and then they labeled as chronic migraine. It can happen because of some other lifestyle factors, or frequency of painkillers, maybe coexisting other illnesses like depression, sleep disturbance, sleep apnea.
Okay.
Many other reasons.
And you mentioned before my medication overuse headache. So how are the headaches different in medication overuse headache compared to a normal?
Yeah. Medication overuse headache is a complication of a migraine. So when migraineurs end up taking their rescue medication, painkillers or triptans, on more days, more frequently, then they end up with a complication when they develop rebound headaches. So the headache then changes because it becomes, instead of one-sided, it can be both sides of head, it can involve neck. It seems like they never recover from their migraine attack, and they have to repeat painkiller. There could be either complete or partial response to painkillers, and they end up in this vicious cycle, taking painkillers more frequently to help their symptoms and cope. But then in between they may have other symptoms like depression, irritability, memory problems, and sleep disturbance as a part of that syndrome.
Okay, and so how would you then go about diagnosing someone with medication overuse headache?
It's a bit difficult to tease out the actual amount of painkillers, but usually there is a history of having a background of episodic migraines, which then gradually got worse, and this is a point when patients come and see doctors. So about maybe 30-40% of chronic migraineurs will have medication overuse when they present to their GPs, and those in specialist headache centers, it could be up to 80% of patients with chronic migraine most likely have medication overuse complication. So we have to determine the amount of painkillers they've taken to conclude the diagnosis, and it's usually more than 15 days of either triptan or painkiller through the month, and it's repeatedly happening for at least 3 months. Then there's most likely this is contributing reason to medication overuse. Also, it's the higher risk if you're using combination painkillers. So there are lots of over-the-counter painkillers which have paracetamol with codeine or ibuprofen with codeine, and most of them also contain caffeine. That's also important contributor.
So with caffeine, some people say it's, it helps them, some people say it doesn't. How would you know then?
Yeah, so there's confusion.
And how do you know which painkillers?
Yes, so caffeine does play a significant role in migraine. You could, if you're used to taking a certain amount of coffee through the day and you missed a couple of cups, then you may be prone to a withdrawal headache. So guidelines state so more than 2 cups of strong coffee regularly, and then you suddenly miss that coffee, you may develop withdrawal headache if you're prone to migraines. And also having sometimes caffeine enhances the effect of the simple analgesics like aspirin, paracetamol or ibuprofen, so it's frequently added into the over-the-counter painkillers. And it can actually clear migraine, especially if they are related to caffeine withdrawal. But overall, so combined analgesics, so they make all this picture a bit more confusing and add to the frequency of headaches and rebound.
Okay, so then how would you go about treating medication overuse headache? How do you actually treat that if it's...
Yeah, so when we suspect medication overuse, the main treatment is explaining to patients that how things got complicated, and the best treatment will be to withdraw painkillers and have, we call it detoxification period, for at least 2 months. So this is a time when they try to avoid their triptans and simple painkillers completely. And it could be quite difficult for first 2 weeks because they have intense headaches and they're restricted, can't treat them. And there are some options when we can offer to ease symptoms and to help this transit.
So what would you, if someone's struggling, sort of going cold turkey, what would you do for them? How would you help them?
Most people understanding how to detox, and that's what's going to be beneficial, to manage to do that. When it's just a triptan or simple painkillers, it can be acceptable to go just cold turkey. When it's a complicated mixture of painkillers and it's been happening for a long time, then we offer some bridging therapies. So it could be course of long-acting anti-inflammatory painkiller, for example, naproxen, taken as a preventive. We offer occipital nerve block as an option. Some treatments like a Botox or topiramate as prophylactic, they proven in studies to reduce frequency of attacks and frequency of medication use.
Okay. And so if someone does stop all the painkillers, does the headache go away? Does it disappear? Will it come back?
Yeah, so one of criteria to confirm diagnosis of medication overuse, that actually the headache got better and cleared completely 2 months after withdrawing that offending medication. But there are maybe about 60% of migraineurs improve after detoxification, but there are some who remain with chronic headache, and there could be various reasons. So the chronic migraine is bad enough and withdrawing painkillers didn't help, so they will need some prophylactic treatment. There could be some other health issues or some underlying reasons. For example, sleep disturbance is an important factor.
Yes. You mentioned sleep apnea.
Yes, so there are conditions, for example, obstructive sleep apnea and some other sleep disorders. They can go missing and undiagnosed if you don't ask specific questions. So people who suffer with sleep apnea, so they snore and they have difficulty breathing and get low oxygen supply to their brain during these apnea attacks. So they develop chronic headaches, and they can be quite groggy and tired through the day, so that's treating that may improve the outcome of headaches.
Okay. Well, I will, because we have quite a few questions, I will get on asking you some questions. So we had one from Lisa. She said, is there any tips for dealing with chronic pain on a daily basis when medication fails or alternative thoughts? Her daughter is 7 months into a chronic daily headache, which can turn migraines at least once a month. Triptans and other prescribed medications don't help at all. She is 15 and a controlled epileptic. So
Okay.
what would you
Yes, we frequently see teenagers who may present with, straight away from beginning their headaches could be quite frequent or in chronic form, in a daily form.
Yeah.
So it can be associated with their, puberty, growth, with stressful time with exams, GCSEs and A levels, and maybe some other health conditions. So I think it's important, if it's persistent, to find out whether there could be element of medication overuse and make sure there is no more than 10 triptans in a month, or no more than 15 days with other painkillers altogether. And when you want to treat the pain without any painkillers, so it will be improving lifestyle and trying to regulate the sleep pattern, so correct if there is a trouble falling asleep for whatever reason, and eating pattern, so meal times should be regular to maintain stable sugar level, and overall that may minimize pain intensity. And also considering some preventive medication is difficult to advise, because if she's epileptic and she's probably on some medication, but there are some anti-epileptic drugs which work as migraine prophylactics as well, so maybe we need to discuss that in more detail if needed.
Yeah. So Lisa, if you are watching and your daughter can come on in, we'd love to see her. And it's hard being a teenager, so
yes.
That's not always fun. Okay, so the next question I've got Claire. She says she's a chronic migraineur. She wants to ask about medication overuse headache. When I read less than 15 days, and you picked up on this just in the last question, but when I read less than 15 days of painkillers and less than 10 days of triptans, I'm never sure if this means doses, i.e. maximum 10 triptans and 15 single doses of painkillers a month, or does it mean days, i.e. I could take 2 triptans and 4 doses of ibuprofen a day? And the difference would be immense, she says. So
yes.
what does it
Yeah, so this is very confusing, trying to clarify this point, both for patients and doctors as well, who prescribe painkillers. So we count the days of using a rescue medication for migraine attack, for headache. And so if you feel you restricted, you get only 6 triptans in your pack and you can't renew it until next month, and you end up dividing these triptans into 12 doses, just taking half a triptan on more frequently on different days. So you end up having 12 days of triptan, and in between, to spare triptan, you use some other painkillers. Then overall number of days you had to treat headache counts, so more than 15 for mixture will be already dangerous.
So it's more the day, so you shouldn't split them over. You should take them.
So if you take triptan, you have these 6 triptans and you had to take them over 3 days because they successfully treated your 3-day migraine, and each time they worked, then you use them only on 3 days, and the rest of the month was relatively pain-free, and doesn't contribute to medication overuse. It's when your underlying frequency is so frequent, is so bad, then you end up using painkiller on each time you need, or sometimes you worry maybe migraine coming and using in anticipation of attack. Then this is when the danger zone.
It's a vicious cycle, isn't it?
It is, yes.
Okay, next question we've got is Scott. He says, is occipital nerve decompression available in the UK? So what's that? What's occipital nerve decompression?
So it's a type of operation which is, they claim that it can improve outcome of migraine. So proposing to remove muscles, like a trigeminal muscle, so remove some of the muscle there, or in the back of the head where occipital nerve, and these are the trigger points for migraine. I think it comes from a study was done years ago, I believe in Austria, when they proposed trying to clarify this trigger point and remove the muscles, and reported to have good outcome for their migraineurs. But actually the studies were flawed and not very scientific, and these type of operations are not used for treatment of migraine, and maybe in future for some research purpose they could be used, but as a treatment option they not recommend it at all.
Okay, so yeah, surgery doesn't sound fun.
Yeah, it's not too drastic.
Okay, the next one we have Kate. She says, I was prescribed pregabalin, hope I said that rightly, because I got frequent mild migraines and irritability, fatigue, anxiety and depression. I now have fewer mild migraines but still get all the other symptoms. The memory loss is frightening. You pointed it out. But I thought these were side effects of the drugs. Reading your info that you gave, it sounds as if this is a type of migraine in itself.
Okay.
Is that right?
Yes, so there could be pregabalin is quite strong medication and it can have side effects. But if you still have headache in milder form but they're frequent, you may also have other migraine symptoms like depression, mood variation, irritability, nausea in between, so and qualifying to chronic migraine. So it can confuse the picture. So overall, if your headache days are more frequent and most likely the rest of your symptoms are linked to migraine, but it could be, again, possible side effect of pregabalin. But memory loss when migraine is in chronic phase is frequently reported. So I think maybe either changing preventive, making sure there's no medication overuse, and maybe just considering another prophylactic or coming to have a chat with us.
Come and have a chat with us, Kate. Okay, next one is Leslie. She says, can you talk about migraine and antiphospholipid syndrome and why people taking blood thinning medications frequently, they're not always, see a reduction or cessation of migraine?
Okay.
Cessation of migraine.
Antiphospholipid syndrome is not that frequent as migraine. But it's a condition when you have higher tendencies to develop thrombosis and clots, so you end up either having some mini strokes or strokes, and neurological complication of antiphospholipid syndrome, neurological symptoms. The migraine can be more frequent. In studies it reported that those who have positive antibodies and have antiphospholipid syndrome, they probably have 3 times more frequent migraines. It's probably not one causing the other, but maybe similar mechanism implicated in the migraine and antiphospholipid syndrome. It's not. There's no evidence that going on some blood thinning medication like aspirin or warfarin improves outcome of migraine. There are some case reports and anecdotal evidence that people who started warfarin, the headache improved, but maybe that could be the case if you do have proven antiphospholipid syndrome, but it's not consistent, and I'm not aware of any studies which proven compared different groups of patients to prove that this would be possible option as a migraine preventive.
So we need more research.
Yes.
Onto that. Okay, what is next? I have Cassandra. She says, I feel like my personality has changed since I started having regular migraines. I feel depressed much of the time. Can this be due to the migraines in a physical rather than emotional response way?
Okay, so depression and migraine are both have neurobiological basis, so it's to do with the chemical changes and disbalance in the brain. So used to say that maybe in migraine there is a relative deficiency of serotonin in the brainstem, and in depression in cortex and other parts of the brain. So they can again coincide and happen together because of the chemical changes, and one can make the other one worse. So if you're depressed and anxious and you more likely you'll have more headaches, but they don't, the one not causing the other. And if your migraine is frequent enough and in chronic phase, as we discussed, you may have other symptoms associated, mood changes as part of migraine. So possibly if your headaches are frequent enough and other symptoms could be part of migraine. And frequently we offer prophylactic medication, which are a special group of antidepressants to address both.
Yeah, I guess they seem very closely linked, don't they? Okay, that's great. I have one from Dawn here. Hello, Dawn. She says, what are the best painkillers for chronic migraine? My doctor has prescribed codeine phosphate and methanoic acid, as mine are menopausal related, but sometimes these don't touch it.
Okay, so methanoic acid is a type of anti-inflammatory painkiller like ibuprofen or naproxen or diclofenac, and frequently offered for period-related pains or endometriosis. So it can be effective in attack of migraine. It's anti-inflammatory, and then we combine it also with a triptan. But we try to avoid codeine at any cost when your headaches are bad enough. And so there is no solution to say what's the best painkiller. It's migraines vary, and some prefer triptans and others prefer anti-inflammatory group of medication like aspirin or ibuprofen. Possibly combination of all of them in a soluble form, high enough dose, maybe throwing in some anti-sickness medication to improve absorption so they can get into the system and clear attack. But again, beware that if you're using those quite frequently and your migraine is already active and frequent, you're at risk of developing rebound headaches and worsening.
Yeah. Okay, have Gail. Gail says, can you explain the difference between chronic migraine and tension headaches?
Okay, so chronic migraine, as we said, is having more headache days through the month, and they have to have migraine quality to them, and other symptoms like nausea, feeling disabled and not able to function because of intensity of headache or nausea, having dizziness with that, and many other symptoms associated with migraine. With the tension headaches, so we call them featureless headaches. So there is a pain, maybe squeezing nature, both sides of head, but there shouldn't be nausea. It shouldn't impair function. So if you, because headache, you can't make to work and you have to cancel commitments, most likely this will qualify into migraine as migraine diagnosis rather than tension type headache. There's also a view that tension headaches count, there could be mild form of migraine. So if you, other than tension headache, you time to time you have bad exacerbations of pain with nausea, vomiting, then most likely they're all part of the migraine mechanism, rather than thinking that you have completely different type of headaches.
Okay. Jane here says, during menopause, will HRT help decrease migraine by regulating serotonin?
Okay. I think during menopause, it's not the serotonin regulation, but replacing the lack of estrogen, relative deficiency of estrogen by HRT. So usually they're beneficial for women who have migraine without aura, and they're prone to hormonal migraines, so they used to have menstrual migraines frequently, and we expect during perimenopause, when there is more erratic estrogen fluctuation, you more likely that will trigger more and more migraines. So then going on a hormone which gives you smooth level of estrogen helps to sort of minimize the migraine impact. Not directly by serotonin mechanism, but probably by correcting estrogen, which then if you have menopausal symptoms and you're sleepless because of hot flashes, if it's all removed and improved, then most likely your migraines will minimize. Also, some migraines, like migraine with aura, sometimes it can get a bit worse if you take estrogen, you go on high dose of estrogen. Also in case of HRT, we prefer smooth release of hormones, so skin formulations like patches or gels are better, and then continuous form rather than interrupted form. If you're already sensitive to hormones, then you prefer having continuous HRT rather than cyclical form of HRT.
Okay.
I think we previous that in our previous Facebook.
So have a look at that one. It's on our YouTube channel. Okay, let's have a look. Susan says hello from Ireland. Hello, Susan. Just having a look here. We had one. Where is it now? Sorry, it's hard to see here. Well, a lot of it's saying about my migraines with aura are causing me to become anxious and depressed. What's the best meds? Sorry, I can't see the rest of it because it doesn't show up on my page. But is there best medication for someone that's become anxious and depressed? I mean, you mentioned that there's antidepressants.
Yes, so they it's a choice of prophylactics, and you can, if there is proper depression diagnosed as part of that. So going on antidepressant group medication, and usually it's a group of tricyclic antidepressants like amitriptyline, or SNRI group antidepressants like mirtazapine or venlafaxine are proven to work, but not other conventional SSRI antidepressants, so that could be an option.
Okay, well, I have my last one, which is from Susan from Ireland. She says, can you take triptans with hemiplegic migraines? I'm probably saying that wrong. Is that right? Hemiplegic.
Yeah.
Oh, okay, sorry.
Okay, so this is hemiplegic migraine is very topical. So everyone mentions this word when they come. So the actual hemiplegic migraine, when you develop weakness and paralysis, is quite a rare type of a migraine, and we think it's genetic and strictly familial. And they try to avoid triptans because there is a narrowing constriction of blood vessels and higher risk of stroke. So triptans are, not advisable. But frequently we have patients who have migraine with aura, and they diagnosed, hemiplegic migraine. So when aura involves having sensory changes, so you have tingling or numbness in the hand or a face, and therefore because of that you can't use it. So it's not proper paralysis and not hemiplegia, but it could be sensory aura of a migraine. So it starts with that aura and then you get a headache attack. So that's not a hemiplegic type of migraine. But then triptans can be taken, so usually in the headache phase of that attack, and during aura phase it will be group anti-inflammatory painkillers, provided they're not contraindicated for you.
Excellent. Well, I think that unfortunately that's all we have time for today. But we will be doing more of these sessions, so please do get us any topics you want us to talk about next time. And thank you, Dr. Manukyan, for answering all the questions today. Thanks very much. Bye, everyone.
Bye-bye.